Karvelas.
And we're going to go back to basics again today. And we're going to be talking about something that is extremely common in our culture and society, patient population, and likely is probably going to get more common as the next 10 to 15 years progresses, because as everybody is aware, we are facing an aging population. And I think that's the reason why our field has actually been such an interesting field to be a part of as we're going forward. And so we're going to be talking about lumbar spondylosis, specifically thinking about ways that spondylosis or arthritis or degenerative changes, how people like to talk about it, really impacts our patients. But before we get there, once again, just want to thank everybody for listening and paying attention. Thank you for reaching out and sending your feedback. We really do appreciate it. And anything that you guys have more questions about or would like for us to lean towards in the future, we would appreciate hearing anything from you. But without further ado, Dr. Karvelas, could you please get us started on some lumbar spondylosis?
Yeah, so as Dr. Joves mentioned, the primary topic today is going to be lumbar spondylosis, with the primary pain generator thought to be facetogenic pain. And as we know, especially as we go through life and we're dealing with issues, pathology coming from the spine, it's typically going to be a multifactorial process in terms of what's causing the overall disease process, the clinical presentation. But part of our biggest job when we are evaluating the patient and working on the optimal treatment is to find that primary pain generator, because that's going to allow us to really make sure we create the best possible treatment plan for the patient. And so the major things that we wanted to cover today in terms of lumbar spondylosis, with the primary pain generator being facetogenic pain, is the definition of that, the epidemiology, a review of some of the pertinent anatomy, the typical clinical presentation, how to approach the diagnosis, and then the treatment. And we'll try to go through that fairly concisely. And ultimately, when we do our journal club and case presentation, we'll probably go into more detail in regards to treatment of this. So starting with definition. So I think a reasonable definition for lumbar facetogenic pain in the setting of spondylosis is a painful disease process originating from any structure integral to both the function and configuration of the lumbar facet joints, including the fibrous capsule, synovial membrane, hyaline cartilage surfaces, and bony articulations. And that brings up a point that the facet joints are a true synovial joint, which we'll get into obviously when we go over the anatomy. So that's our definition. Now, in terms of the epidemiology, if you look at the studies, there's like a lot of our chronic pain disease processes, and especially when it comes to the spine, there is a huge range there, and we're continuing to work on optimizing these statistics. Part of it comes from, who is doing the study, what's their methodology in terms of making the diagnosis. Are they making the diagnosis based on the clinical exam and clinical presentation? Or are they making the diagnosis based on interventional procedures? And if they are doing interventional procedures, how exactly are they doing that? So bottom line is there ends up being a huge variability there. If you look at some of the larger studies, some studies document a 4.8% incidence of or prevalence of facetogenic pain versus others as high as 50%. But I think if you look at the majority of the studies done by interventional spine primary investigators or interventional pain primary investigators, the statistics tend to be around 15% of chronic low back pain being predominantly due to facet pathology. Like I said, we know there's going to be multiple contributors ultimately when we get to this situation where we are having the degenerative cascade of the spine. But in terms of finding that primary or significant contributor to the pain, about 15% being predominantly due to facetogenic pain.
Yeah, and that's the pain that, as I kind of referenced earlier, our population is coming to a point where over the next, 5 to 10 years, we're talking about this extremely large increase in the percentage of the population over 65, the percentage population over 80. And so as we're thinking about these degenerative changes that do happen in the spine for everybody, we expect that that's going to continue to be a very large contributor going forward.
Yeah. So moving to the pertinent anatomy. So as we brought up previously, the facet joints are true synovial joints. And this is kind of specifically if you're going to be doing these interventional procedures, just keeping in mind that these are obviously small joints and they typically hold about 1 to 1.5 milliliters of fluid. Like I said, obviously that comes into play if you're thinking about intervening therapeutically upon these joints. But these synovial joints obviously have a synovial membrane, and they also have hyaline cartilage surfaces, and then this fibrous capsule. And one important anatomical thing about this fibrous capsule is that this capsule has quite a bit of nociceptive nerve endings, as well as, interestingly, sympathetic nerve endings. And we've talked a great deal about how the sympathetic nervous system can contribute to the chronic pain picture. So I just thought that those were important and interesting anatomical facts, is that there is quite a bit of nociceptive receptors in the fibrous capsule of the facet joint, as well as these sympathetic nerve endings.
Yeah, and I think that the capsule, which we're not going to get too far into today, we're obviously focusing on spondylosis, and that in reference to facet arthropathy. But the capsule plays a big factor when we think about other pathologies of the facet joints, mainly when we think about things like whiplash and things along those lines. And so, that's not our focus today, but just as a reminder that capsule does play a significant role in some very specific pain pathologies.
Yeah, and so finishing up with the discussion regarding the anatomy, anytime we're thinking about the anatomy of the spine, it's critical that we know that the basic anatomical unit of the spine is going to be that 3-joint complex, which is going to be obviously composed of the intervertebral disc itself, and then the paired facet joints or zygapophyseal joints. And the orientation of those joints in the lumbar spine becomes critical, because typically when we think about the orientation of the facet joints in the lumbar spine, as you get to the lower facet joints, the 4-5 and the 5-1, which we know from studies that the majority of the stress, especially from a flexion extension standpoint, is going to go through those 4-5 and 5-1 joints. So some studies showing 80 to 90% of that flexion extension occurring at those joints, which is why when both on imaging as well as on exam, and when we're doing our treatments, those joints tend to be our primary targets and tend to be the primary culprits in terms of causing pathology for the patients. But as we get to those 4-5 and 5-1 joints, the joints become more coronally oriented, in contrast to being more sagittally oriented higher up in the lumbar spine. And the reason that this becomes important is because when we have situations where we've actually, when you've looked at individuals who have more sagittally oriented facet joints at the 4-5 and 5-1 joint, that actually is a risk factor or predisposes them to the development of degenerative spondylolisthesis and ultimately debilitating pathology for that patient.
Can you take a second to define spondylolisthesis for us, just for those that are listening and may not know what that means?
Yeah, and so listhesis simply meaning that when we look at the alignment of the spine, rather than that alignment that we all have in our teens and 20s, that's nice and in line in terms of each vertebral segment up upon the other, with listhesis, due to typically what we're talking about here in terms of spondylolisthesis in this setting, typically is going to be degeneration. So the degenerative cascade of the spine with the disc starting to degenerate, and then ultimately placing more stress on the facet joints themselves, and ultimately leading to movement of one level over the other. And obviously there's gradations for that, but the bottom line is that now each vertebral body is not sitting directly on top of it itself, but there is some slippage or movement there, which we term listhesis.
Yeah, no, I think, another analogy that I like to use with patients is, if you have a stack of books and they're all stacked neatly on top of each other because somebody pays a lot of attention to how that goes, it looks nice. But if you just kind of push a couple of the books forward so that they're not directly on top of each other, I think it paints a very simple picture of what listhesis means. It's not aligned the way that you wanted to. Yeah, sorry.
Yeah, and so just to wrap up, in terms of talking about the alignment of the joints and why that's so critical, that it's so critical because that is the primary function of these facet joints, is really to limit the movement of the spine in certain planes and to allow movement in functional planes. There is some role that facet joints play in terms of loads, including axial load, but as we've talked about in prior podcasts, that's predominantly through the intervertebral disc in terms of taking on those loads, and it's the facet joints' job to allow movement in certain planes, but then to protect from movement in other planes.
Yeah. For a deeper dive in that, please reference the golf podcast of last spring.
Yeah. So moving to the pathophysiology of facetogenic pain in the setting of spondylosis. So more infrequently is this going to be a sudden onset of facet pathology. When you look at pain due to facets, the overwhelming majority of what you're going to see clinically is going to be facetogenic pain due to repetitive stress or repetitive microtrauma in the chronic setting. So, and we'll talk about this when we get to the clinical presentation, but typically when patients are describing this, it's going to be an insidious onset. They're not going to be able to give you a specific time when this really started, but gradual onset that has worsened over time. That repetitive strain and trauma that can occur ultimately leads to some pathologic changes, which include increased fluid in the facet joints themselves, which is then going to lead to distension of the capsule, which we already talked about, how any stress or strain on that capsule that's full of nociceptive nerve endings can then lead to obviously persistent firing. And going back to some of our other podcast where we talked about some of the therapies for axial low back pain. And I bring this up because when we're thinking about the pathophysiology of facet pain, there is a significant component to the peripheral and central sensitization that ultimately occurs. And so when we talked about things like peripheral nerve stimulation, which can have a positive impact on that, it goes back to what's the underlying mechanism. And, with this chronic repetitive strain and microtrauma to the facet joints that can occur over time, like I said, yes, we get the inflammation, increased inflammatory markers, and we get that increased fluid in the joints and the chronic stress on the joints. But when that really becomes a problem is when that's persistent and continues to fire and starts to become more ingrained in our nerves and our nervous system. Yeah. So the other thing I did want to talk about here as well is that in addition to the distension that can occur that leads to the firing of the nociceptive neurons, that distension can also start to involve certain points of the facet joint capsule, including the articular recesses, which especially when we start to have degeneration of the spine, is in very close proximity to the nerve root. And so it's not uncommon that as facet joint disease progresses, that there can be some level of irritation or even compression of the exiting nerve root, especially, like I said, if that foramen is already narrowed by facet hypertrophy and other degenerative changes of the spine. And so like I said, not uncommon, not only for the facet joint itself to have somewhat of a referral pattern, which we'll talk about in a moment, but that facet joint pathology can ultimately lead to nerve root irritation, inflammation, and compression, which obviously is going to cause somewhat of a radicular referred pattern as well. The last thing I'll mention in terms of pathology here is that the facet joint irritation can commonly lead to a reflex spasm of the paraspinal musculature. So this becomes important, I think, too, when we're talking to patients about how we're going to target their pain, because they may feel their pain kind of up and down the lumbar or even thoracolumbar spine. And so it's not uncommon. I'm sure Dr. Joves has experienced this too. When we're even when we're doing the procedure and or telling patients where we're going to target the procedure, they'll be like, no, but my pain is, not just there, it's up and down here. And that's where it's important to educate them that true and yes, and we'll keep our mind open to other diagnoses, but based on your symptoms, your exam, your imaging, we believe that this 4-5 and 5-1 facet joint, is like we talked about, chronically having repetitive strain and microtrauma, and there's increased fluid there. There's increased inflammatory markers there. That's leading to pathology, including this reflex muscle pain and spasm, and especially when that muscle pain and spasm is chronic, the patient can really start to feel pain kind of up and down their mid to low back, but letting them know we're trying to get to the root cause of that.
Yeah. I think it's really important that we always emphasize, and I know that if you listen to our podcast, you've heard us say this, by the time most of these patients make it to us, by the time a patient has severe enough, spondylosis and degenerative cascade that, the facet joints have hypertrophy, that, their discs have flattened, their muscles are spasming, this is chronic multifactorial pain. Yes, we believe in many of these cases that the facet joints themselves are the primary cause of the pain, but they do have pain that is encompassing many other factors. And it is very common for pain not to be just purely one factor. That's the only thing causing pain.
Yeah. Yep. And I just wanted to bring up one last study because I think it's kind of an important study when we think about understanding and counseling patients on the natural degenerative cascade of the spine, because like I brought up, unless it's a rare situation with an acute injury to the facet joint itself, typically we're going to be dealing with degeneration and loss of structural integrity of the spine itself, and the point I wanted to make is specifically, usually it's the disc degeneration that is going to be present and precedes the facet joint degeneration. And this was kind of demonstrated through multiple studies, but I thought one study I wanted to bring up was the study by Dr. Fujiwara and his colleagues in 1999 that found, essentially they looked at a large number of imaging, obviously advanced imaging MRI studies. And what they found was that facet degeneration was rarely present without disc degeneration. And typically it was more pronounced when there was more advanced disc degeneration. And so essentially taking that data and synthesizing it, they came to the conclusion that usually disc degeneration is typically going to precede facet arthropathy.
Yeah.
So now just wrapping up real quickly in terms of the clinical presentation, as well as the treatment for this. And like I said, we'll probably dive more into the nuances of treatment with our coming up discussions. But, when we think about the common clinical presentation, as we talked about in other discussions, we always want to think systematically about it. What's the location? What's the quality, the radiation, the timing, what's making it better and what's making it worse? So what's the associated symptoms? So in terms of localization of this, oftentimes the patient is going to be predominantly reporting axial low back pain, but like we brought up, that you can have that nerve root irritation, you can have the referral pattern of the facet joint itself. And so, the referral pattern of facet joints has been studied quite a bit, including with procedures where you artificially distend the facet joint capsule and map that out, and or you anesthetize the facet joint and then map out where the improvement in the symptoms occurred. And so with the combination of those studies, you can start to get a sense, and bottom line is, again, there's quite a bit of variability, and as we've talked about, there's definitely flaws in terms of, when you're artificially inducing this capsule distension, is that truly going to represent what happens naturally or in a patient? But with understanding the limitations of this, some of the common referral patterns, especially for those lower lumbar facet joints, is going to be referral of pain into the thigh, and especially the posterior and lateral thigh is a common place for that lower lumbar facet joint pain to radiate.
Yeah, one of the things that I hear most commonly from patients is, that the pain is in their low back and it kind of radiates across the low back, kind of like a band. Like it's amazing how I remember hearing that in residency, and one of our attendings said, "Oh yeah, it's like a band across your back." I'm like, "Oh, it's an interesting way of describing it, as if I kind of thought she was making it up." And then you go through it over years, and I mean it's a very consistent way that people describe it. It's like, yeah, I have this aching band right across my low back, right around my belt line. And then like Dr. Karvelas brought up, it definitely can have some radiation, into the buttocks down towards the posterior lateral thigh. Generally speaking, not below the knees when we're thinking about those joints in the back.
Yeah, exactly. To Dr. Hoves's point, it's pretty rare. There's a few documented cases, again, understanding the limitations of anesthetizing those structures and inducing, artificially inducing. There's some, cases of the pain going as low as the leg or the foot, and leg meaning the calf, in contrast to the thigh. But for the most part, it's going to be that thigh and the posterior lateral thigh for our usual culprit joints of the 4-5 and 5-1. So Dr. Hoves also brought up the pain kind of going across the back, and I think that's a good point too, because some things that would lead you to start to be suspicious of facet pain would be when the patient's reporting pain that's not exactly midline, which may make us start to think about other pathology, maybe a discogenic type of presentation more so. But when the pain really lateralizes out to the side, that should raise some thought process in terms of facetogenic type of pain.
Yeah. What other things do you usually hear from patients, or do patients usually kind of talk about when we're talking about this, right? So we talked about that aching pain. We have pain diagrams for our new patient intakes, or actually for every patient as they come in to visit us. And X is aching. And generally speaking, if we're thinking about this kind of lumbar spondylosis with facetogenic pain, patient will draw X's just right across their low back, right around the waist. I think that's a very common thing that I see. What other things do you hear from patients?
No, I absolutely agree. I think that probably one of the most common reports I hear from a patient when they're talking about, and I suspect that it's going to be predominantly facetogenic, is they'll tell me, just like you said, when I ask them to describe the pain, they'll say they have persistent aching pain that's sharp with exacerbation. So it's kind of this baseline ache that's with them the majority of the time, but then it can get sharp with exacerbation. In addition, it can be really severe when they're kind of in a prolonged bent forward posture, which makes sense because when we look at the studies demonstrating what positions put the facet joints on stretch, being in that kind of prolonged, partially bent, lumbar flexed forward position can put a lot of stress on the capsule. And then also, if they're sedentary, for a while. So for example, if they sleep all night and then they go to get up, before those joints really start to produce their synovial fluid again, and or if they're sitting for a long time, then go to get up. Those are common complaints in terms of it can be really uncomfortable with that initial going from lying to sitting to standing, or that prolonged sitting to standing. And then as they move around a little bit, it can potentially get a little bit better before it gets worse again with too much activity. Yeah, those are some of the more common things I've heard. And now in terms of the diagnosis of this, so the key point here is that ultimately it is a combination of the clinical history, your exam, and then diagnostic blocks. And there's, at this point, there was a recent consensus paper that really kind of did a good job of addressing this that we'll include in the show notes. But the overall strongest recommendation is to consider doing medial branch blocks in contrast to putting medicine intra-articular itself. And there's various reasons for that. We won't get into too much detail here, but the bottom line is it's really that combination of the history, your exam, and then the diagnostic blocks, really two diagnostic blocks with greater than 80%, although again, you'll see 50 and 80% out there, but really we're looking for 80% improvement in their typical low back pain with the diagnostic block with local anesthetic. When we're thinking about the physical exam to date, although this has been because this is such a common pathology, it has been extensively studied, but to date, there's no pathognomonic finding on physical exam for facetogenic pain. That being said, if you have someone that comes in and they report axial low back pain that's not predominantly midline, but radiates out to the side, and you have significant tenderness to palpation over the facet joints, those things have been shown to be mildly positively associated in terms of leaning towards. So that's definitely at a bare minimum something you should be thinking about if you're going to make that diagnosis on history and exam, is that you have palpated over the lumbosacroparaspinal area and you do feel like that there is increased tenderness to palpation over those facet joints.
Yeah, and one of the things that you'll also see sometimes in guidelines when we're thinking about diagnosing and then being able to provide interventions for people is the facet load. And I think we probably fall along the same lines where it is when positive, it is extremely useful. But because facet pain doesn't, or spondylosis pain doesn't always act up instantaneously with loading of those joints, I think it's a lack of a positive facet load doesn't mean that this is not facetogenic pain, right? But it is a part of many guidelines. I know specifically, when we think about things like the MTUS and ODG, which are utilized for workers' compensation, they specifically ask things about, positive pain with facet loading, which, like I said, when it's there, awesome. But when it's not there, I don't particularly think that it's overly against facetogenic pain.
Yeah, exactly. Yep. And like I said, we'll just briefly mention this because we'll get into the details of this in much more extensively moving forward. But as always, when we're thinking about the treatment for lumbar spondylosis with facetogenic pain being the primary pain generator, we always want to think about lifestyle modifications, diet optimization, exercise optimization, therapies, equipment, in terms of durable medical equipment, medications, procedures. Are there any minimally invasive surgeries? We brought up the peripheral nerve stimulation, and then, as always, importantly, further diagnostic workup, ruling out, other processes that may be present. So the only thing I'll just mention here is, and we've actually talked about a few of these different therapies, but in terms of the things that really have shown good effectiveness and tried and true in terms of treatment of facetogenic pain, obviously radiofrequency ablation being one of those. And then especially if patients are not responding to radiofrequency ablation, and or you do not think that the ideal candidate for it for various reasons, maybe including their age, peripheral nerve stimulation of the medial branches is definitely something that's growing evidence in regards to having a positive impact for these patients too.
Yeah. And the thing that you can't forget, and I know that we talk about this often, so I'm pretty sure none of you that are listening would ever forget this. But the reason we do interventions, the reason why we have medications, the reason why we do, any of these procedures for patients is because we want to help people be more active. And that activity, that building of the core strength, that working on the flexibility, really, especially when we're talking about things like spondylosis, can be very, very helpful for patients, right? That is something that over the long run, the stronger that those deep core muscles are, the more flexible they are. So they're not in constant spasm. So they're not too tight and therefore causing abnormal strain across those joints and discs. That is going to help them significantly in the long run. Even things such as weight loss. I know the data is much more versed when we talk about weight across like the knee joints, with every pound of weight loss being 4 pounds. I know that there are similar studies for the low back that would suggest similar numbers, but little bits of weight loss can cause significant decreases in force in the low back, and all of that is the reason why we want to control the pain, so they can do those exercises, and those exercises and that consistent program is what's going to lead them to be more functional in life, right? What's going to allow them to do the things that they truly want to do in life.
Yeah, I think that's a great point. And it's tough because, especially when someone comes in and you do feel like that facetogenic pain is their primary issue. Sometimes the patient is frustrated and they're like, hey, I don't want, they may call it a Band-Aid, or I don't want, I want to get to the, root of the issue. The reality is, we don't have a treatment that's going to take the arthritis out of their body or reverse it. Of course, things like platelet plasma and stem cells, which we've brought up in the past, may have, some positive effect in terms of minimizing the progression of that degeneration. But the bottom line is arthritis is a natural process that we get as we go through life. And so I think that what Dr. Joves brought up is the key when we're talking to them, that really, if you do want to try to get to the root of the issue as best as possible, the foundation of that is going to be the optimization of the structures around the spine. Because, and the way I put it to patients is, the spine, just like any other structure, if you have a building, the better the support around that building, the less pressure on the individual elements. And that's, really what we're trying to accomplish. Like Dr. Joves said, the medications, the procedures, the other interventions, those are all great in terms of breaking the pain cycle, decreasing pain and inflammation. But the importance of that is then to allow the patient to get to a position where they can strengthen all the structures around the spine to put less stress on the joints. So it not only helps with their current symptoms, but helps prevent further degeneration down the road.
Perfect. All right, guys. Well, that is our deep dive into lumbar spondylosis, with including the pathophysiology and mostly the clinical presentation and the things that we see on a regular basis. We will, as Dr. Karvelas said, be diving a little bit deeper into some of the interventions and kind of talk more specifically about, what we normally see with patients as they present to us. If you have any questions, reach out to us, drop us a line. If this was interesting or entertaining in any ways, probably less entertaining than it is educational, but we'll work on the entertaining part. All right, everybody, have a great day and stay tuned for those legal disclaimers.